Hello, hello, everybody. Welcome to the very first inaugural interview for the Pelvic Health Explorer. I'm excited to be here and present with my colleague and friend, Colleen Hickey. And Colleen is the uh, Pelvic Health Program Director for Corvia and has extensive experience working with males from prehab to rehab with post-prostatectomy. Colleen, come on in and introduce yourself a little bit more. Tell everybody who you are. And she's brought a really nice presentation for us today. So if you're listening to this, you might want to at some point tune in and see the slides too. So we have a double presentation today.
Great. Thank you, Susan, for inviting me. I am happy to have the opportunity to talk about this patient population that I have a passion for. What I thought I'd do is just talk about our experience over the past few years in building a relationship with a group of urologists who do a lot of prostate cancer work. So we see all of their patients pre-op and then post-op. And I thought maybe some of the things I've learned would help somebody else make the connection maybe a little quicker than I did originally so that they can use that information to inform their practice.
I think that's awesome. We always say, or at least I always say, that we stand on the shoulders of giants. Somebody else
Yeah.
has come along and put the work together, and we all learn and benefit from, the years of exploration and work that you've done in this area.
Yeah, totally true. So, and by way of introduction, I am a physical therapist. I've been one for 38 years, which seems like a long, long time. Done a lot of different things, and got into pelvic health about 10 years ago. So that's really where my passion and my love is now. I'm also recently, in the last year, developing a national pelvic health program with Select Medical. So that is building a pelvic health program. I won't say from the ground up because a lot of our facilities have pelvic health, but it's certainly creating some consistency, making sure the competency is there, making sure the resources and the things that we want to provide in terms of a program. We have two main goals. One is to increase access. The other is to enhance quality. So that's what we're truly focused on. And we're rolling out that program as we speak.
That's so exciting. And it just means more access for people who really need this work.
Yeah, and as I always say, when there's more access anywhere, that's better for everybody, because
Yes.
that means that referral sources are aware and patients are aware that, pelvic floor therapists, PT or OT, are out there to help them.
Fantastic. All right. So tell us a little bit about this radical robotic prostatectomy program.
So I'm going to speak to what I know well, which is the radical robotic prostatectomy. And I'm just going to start with a bunch of information here, and you can certainly stop me to ask questions at any time. Just see if I can advance my screen. All right, so there's me again, and the name of our program is Corvia. So that's Corvia Pelvic Health. And I will say that I met with Susan a few months ago. She presented at a conference for us with the APTA, a pelvic health specific conference, and she did a great presentation, and it really spoke to me, especially one part of it in terms of the 4-6 breathing method. So the 4-6 breathing method is something that I've adopted with our pre and post prostatectomy patients. So I'm going to include that today in this discussion. But I do think that, it's not something that everybody talks about in terms of pelvic health or in terms of pre and post prostatectomy. So the idea that we both were incorporating that in our work, in different types of work, I thought was really interesting. So I wanted to highlight that today as we go through this. So in terms of having a pre and post prostatectomy, we first wanted to delineate kind of what our value was as physical therapists. we wanted to work with the local surgeons in terms of developing this type of program. We knew that some patients wanted it, but we weren't really sure where the surgeons stood. So this was about 3 years ago, right around the time COVID started, which made it a difficult time to start a program. But what we were able to offer these doctors and surgeons was that we could guarantee them highly competent clinicians who were specialty trained. We could promise timely access for these surgical patients. And most importantly, I think, is that we wanted to be a member of that patient's care team. So we were just one more member of the team that was included in their journey. And in speaking to the surgeons and trying to get them interested in the pre and post program, we went back and looked at what literature was out there, what evidence was out there that would appeal to them particularly. So this is the American Urological Association recommendations in terms of radical prostatectomy. And the first item in that recommendation is the pelvic floor muscle exercises or pelvic floor muscle training should be offered with a grade evidence level of a B. And so that really appealed to the surgeons to see that at the top of the list. And this is their own list, right? So it's everything that they put in there. The other thing we did is just present articles or literature or anything that comes out about our role as physical therapists or occupational therapists in this process. So I've highlighted some of those articles here in my slides. This one in particular is interesting because it says it would be prudent for all men to exercise their pelvic floor muscles to maintain normal pelvic floor function prior to surgery. So this was kind of at that preoperative. Sorry, my slides here. All right. And then this also spoke to us in terms of supervised pelvic floor muscle exercise is more effective than unsupervised pelvic floor muscle exercise at improving urinary incontinence in prostate cancer patients following a radical prostatectomy. So this was systemic review, definitely gave us more information to provide to the surgeons. And they really started to buy in when they saw these studies. Additionally, more information here. And then also pointed to quality of life. So we tried to find some things that really highlight the difference that we feel we provide as a member of the patient care team for these patients. So ways that we are, by doing a pre-op program and then following post-op, able to increase the confidence of the patient, enhance self-efficacy, and lead to better outcomes overall. And again, the surgeons really, really liked that information was out there. They just didn't really know about it. So in terms of prostate cancer, for anybody who's not familiar with it, just a quick overview. So the prostate gland lies on the pelvic floor in contact with levator ani. It grows from a pea size to a walnut size over 30 years, and it's the shape of an inverted round cone. And its job is to forcefully press semen into the urethra to be expelled. And what we know now with prostate cancer is it's the second most common cancer in men, the 5th leading cause of death worldwide, the 2nd leading cause of cancer in the US, and the 5-year survival rate on a local or regional type of prostate cancer is 100%. If it's metastasized, more around 30%. And the 10-year survival rate for these patients is 98%. The incidence, I have the number of cases there. The majority definitely over age 65. We definitely see our average age is around 66 years old. And then the other data there, just survival rate and how many men will be diagnosed with prostate cancer in their lifetime, about 12.5%. And then in terms of prevention, there are some things that are out there that have been in the literature and research that people feel pretty confident with. So smoking and obesity may increase the risk and the mortality. Engaging in physical activity, especially if it's vigorous, especially any kind of walking, would assist in prevention. And consuming a diet rich in vegetables, so interestingly, particularly tomato sauce and cruciferous vegetables and vegetable fats would lower the risk. In terms of prostate cancer, usually asymptomatic until a late stage, so it's kind of that silent type of cancer. It's detected by what we call a PSA, so you usually hear in November a lot of advertising about getting your PSA if you're a male. And then there are scoring systems for prostate cancer. So you'll very often hear your PSA score, your Gleason score, and then types of following with prostate cancer. So there's active surveillance. So, you know, sometimes you'll have an elevated PSA and the doctor will do active surveillance for a few years prior to having a diagnosis. There are also other types of treatment besides what we're talking about today. So there's radiation, hormone therapy, and other types of surgery that have been done. And in terms of radiation, there's definitely a higher mortality. There's the seed implants and the external beam radiation. We're not going to go into that, but just so you are aware that that's also there. Surgery is definitely the gold standard today. Most of it today is that robotic assisted surgery. So we've come a long way with this. The robotic assisted surgery's primary goal is to remove the prostate, the prostatic urethra, and the internal urethral sphincter. So this is one of my favorite pictures because I kind of think it's a great way to just very basically see what's going on here. So the green arrows, those are the points where the actual surgical incisions kind of take place. So this is robotic. They're going to go in just below the, let's see if I can get my cursor here, just below the internal sphincter and just above the external urethral sphincter. And so then this pink walnut-shaped size thing is that prostate gland that they're removing, as well as the urethra that's in that area, which is about 4 centimeters long. So when men typically will say, I feel like my penis is shorter after the surgery, it's really true. The length of the urethra has actually been shortened by about 4 centimeters. So if we look at it in this diagram, in that first picture, we can see how the urethral closure pressure happens when the prostate is still intact. That second or middle picture, we can see with the prostate removed and how that urethral pressure would now have to contract. And in that third picture, we can start to see when there's a downward pressure on the bladder, how much different the action is to actually close with urethral pressure. And then this is just another way to kind of point that out. So if we talk about that internal sphincter where the initial cut is made, that's at the base of the prostate. That area controls the neck of the bladder and the prostatic portion. This is smooth muscle, and it regulates the involuntary flow of urine from the bladder to the urethra. If we talk about that external sphincter, which is preserved, that is striated skeletal muscle, so it's easy to train, right? It's innervated by the perineal branch of the pudendal nerve, and it's a voluntary muscle and controls the flow of urine. All right, so the importance of those urethral sphincters then we've talked about, but with all of this information that I'm giving you now, I typically go over this with the patients as well. So I show them this picture in our pre-op program and talk about where the surgery takes place, what happens, and then what the importance is of the loss of the internal urethral sphincter and how they need to enhance or work on the control and the coordination and the strength of the external urethral sphincter, which is why they come to us preoperatively. And then urinary continence as a definition can only be maintained when the pressure in the urethra exceeds that of the bladder. So as a result, if you damage or eliminate that striated urethral sphincter, you can end up having leakage, particularly with any kind of intra-abdominal pressure, like coughing, sneezing, movement, anything like that. All right, so in terms of the surgery technique, the Da Vinci is pretty much the standard, and the pros related to the Da Vinci method are listed on the left-hand side, cons to the right-hand side. And you can see there one of the big cons is increased incontinence, and the second one is increased erectile dysfunction. We're going to talk a lot about incontinence today. We might get to erectile dysfunction, but if not, that would be a great topic for another time. In terms of the radical robotic prostatectomy, one of the most difficult things about this that the men complain about is the catheter that's in place for 7 to 10 days post-operatively. There's also no lifting more than 10 pounds for about 4 weeks, and then no riding or straddling anything for about 3 months. So bike riding is out, horse riding's out, anything like that. I told you there's also hormone therapy. We're not going to get into that today, but that could also be a complication in the process. So this is that radical robotic approach to removal of the prostate gland. And you can see here, there's typically 5 to 6 incisions, depending on the surgeon. And I'm going to speak specifically to the surgeons I work with at UPMC. And so primarily I'm working with Scott Owens, Chris Caputa, and Nathan Brooks. So these are the little incisions that you'll also see post-operatively. And one thing I want you to notice about this picture is that the belly here is pretty distended and full, and that's from the CO2 that they have to put into the belly to blow it up so that they can easily see inside when they're using all their robotic tools. And remember that that gas sits in there and is there immediately post-operative for about 3 days. And during that time, the typical prostate patient may complain of pain up underneath the diaphragm. And that pain, most of the time, is coming from that gas that's sitting up underneath the diaphragm. So if we look at this a little bit differently, again, in the picture far to the left, you can see the prostate gland intact. The second picture there, you can see the prostate gland is removed. And now you can see the new conjunction of the urethral sphincters. So they've taken the area that was where the internal urethral sphincter is, connected it to the external urethral sphincter, and then reconnected the urethra. Okay, so pre-prostatectomy. Why have a pre-prostatectomy program? So I believe empower with knowledge, right? If you can give the patients the knowledge, they are going to have more power. They're going to have more say in their decisions. They're going to know what they should do and what they shouldn't do. And they're going to know that they have a resource to go back to and ask questions of. So pelvic floor therapists are the perfect person for this. They are people that can follow them both preoperatively and postoperatively. No one else on the team really does that on a regular basis. So the surgeon will see them for their surgery, but then typically only sees them 1 or 2 times post-op. So we're really the perfect person for this. Our goal is really working on strengthening those pelvic floor muscles through hypertrophy, the bladder training, reconnection of the motor patterns and the use of the external urethral sphincter, and then strengthening that external urethral sphincter to contract more forcefully and therefore withhold more load. So how do we get there? So it starts prior to surgery and resumes after catheter removal. So nothing while the catheter is in, and I'll say that about 50 times because it's very important. The primary focus during this time is to focus on strengthening that striated urethral sphincter. And we do that in several different ways, just to give you examples as we go through this. So we can say things like, imagine you're peeing up a wall, not contracting the anal muscles, but focusing more around that feeling of scrotal lift and retraction of the penis. So the important message with all of this is that if you don't do it correctly, it's not going to help you. Again, another reason why we need to see them preoperatively, get them used to using those muscles, and then also follow up post-operatively. So that prehab training occurs about 30 days prior to surgery. If you can get them sooner, that's great. The pre-op pelvic floor exercises are geared towards improving early continence and quality of life. We strengthen those pelvic floor muscles to improve post-prostatectomy urinary function, to reduce post-micturition dribble, and to assist with erectile dysfunction. And then we decrease the duration and severity of urinary incontinence following post-prostatectomy. And in terms of research that's out there, so this is that research that's specific about increasing that pelvic diaphragm thickness, and the ratio of levator ani to prostate volume are those independent factors predictive of our incontinence. So patients with better developed pelvic floor muscles can be expected to achieve earlier recovery of continence after the surgery. So pelvic floor muscle instruction, 1 to 2 exercises. We teach them how to Kegel. We teach them other cues as well, as we've mentioned a few. We actually work on cueing to relax the abdominal muscles, and a big one here, avoid holding your breath. One of the big keys to having success post-operatively is the ability to learn how to not hold your breath with functional activities. We'll get into that a little bit more. And then you can use biofeedback or ultrasound to help the patient confirm that what they're doing is what we want them to do. And they actually appreciate that visual so that they know what it feels like when they make that visual happen. This is a typical exercise program we might give them. We also let them know that fatigue's common and often the root cause of the pelvic floor muscle dysfunction. So we tell them, do their high-level activities in the morning. Try not to do those things in the afternoon because the muscles are going to be more fatigued, right? And then to take time to exercise, take time to nap, help recover over time. We also talk to them about maintaining that urethral closure pressure, not just lying down, but particularly in sitting or standing and with functional activities. With all of the men we work with, we encourage a walking program. And again, we're going to talk about that more as we go through there. But this should definitely start preoperatively. Don't wait until afterwards. In terms of urinary continence, we talked about this definition already. So urinary continence is maintained when the outlet or urethral pressure is greater than the storage or bladder pressure. And so in terms of urinary incontinence, compliant bladder, competent urethral sphincter, and that complex has to work together. So you'll see a lot of our exercises here work on both control and coordination, as well as strengthening. We talked about that urethral closure pressure maintained by the prostate, the internal urethral sphincter, and then the filling phase and the, emptying phase with the detrusor contracting and the internal urethral sphincter relaxing. So now we're missing that internal urethral sphincter. So we've got to come up with a way to demonstrate how we're going to correct that. So I use this picture a lot because it has a nice representation of what we try and do with hypertrophy of the pelvic floor muscles and where that fits into where the prostate gland was and the urethra. Sometimes we'll do functional assessments as well, and we definitely measure with outcomes. So one of the outcomes we really use with this patient population is the Promise Global Health outcome. And we use that because it is geared towards quality of life. And we really feel like with these patients, quality of life is a big issue. So learning to breathe. Again, this is where Susan and I kind of intersected. So over the years that I've been working with this patient population, I think the most important thing I've been able to teach these men to do in order to have the least amount of incontinence post-operatively is to learn how to breathe. So I will spend my first session, sometimes a second session preoperatively, and then even if I need to post-operatively spend sessions, just making sure that they know how to breathe, making sure that they know how to exhale with functional activities, And a long way towards that breathing is teaching them specific types of breathing. So we'll talk about that 4-6 breathing that we integrate. I also try and make them understand the diaphragm and the function of the diaphragm. So we give them pictures and kind of talk about like holding around their rib cage and doing some lateral breathing and some rib breathing, just trying to figure out how different types of breathing affect different types of their body, whether it's diaphragmatic or belly breathing or posterior breathing, 360 breathing, almost anything. In this picture, I think one of the other things that I found over the last few years is that I mentioned earlier, there's that pain that a lot of the men will have post-surgically for up to about 3 days. The problem with having pain is you want to take pain medication. And what do we know about pain medication? It enhances constipation. So these are people who should not have constipation because they cannot afford to be bearing down or any kind of Valsalva type thing with a brand new urethral sphincter, right? So that urethral sphincter has been constructed. Any kind of pushing down against it is not a great thing. So those two things kind of made me think, okay, what's going on in the diaphragm and how do we get rid of that gas as quickly as possible? That's the 4-6 breathing, right? Introduce that 4-6 breathing immediately post-operatively. You've learned it preoperatively. Start it immediately post-operatively to start to spend that gas, get rid of that gas that's sitting in that area. The other part of that is to get up and walk around frequently. So typically have people walk for 4 to 5 minutes at a time, many times per day from the very first day on. That really seems to help with the pain management part of it, and it reduces the need for the opioids or any kind of medication that's going to create constipation.
Colleen, in your program that you all were working with, was this done as an outpatient procedure, and they were just kept till they were through recovery, or were they in the hospital for a day or two?
They are in the hospital for 1 to 2 days.
Okay.
Yes.
Which makes a great reason for everyone out there to understand that we need to be part of the post-surgical team. We need to see these people post-op in the acute care. There's I know a lot of people have been talking about acute care for postpartum, like immediate postpartum, post-birth. This is a really good reason why we need to be in there the day of or right after surgery so that they can do these techniques that they're learning pre-op in the moment when they need them.
Exactly. And so I'll go back to this picture for a minute on the right side of the screen. This is when the gas doesn't move and it gets trapped, right? And we've probably all had people who had that complaint of like shoulder pain post-operatively, and you didn't really understand what was happening there. But when they complain, particularly of that right shoulder pain, that is gas that's sitting in there post-operatively. And when you think about the lungs and the filling up with air, so the lungs don't have any issue typically. It's more the diaphragm. The diaphragm becomes more rigid, and when it becomes more rigid, it's difficult for it to kind of do that trampoline kind of effect with the muscles. So they're not flexible, they become more rigid, and it's more difficult to manage pressure in that intra-abdominal area. So another reason to start that 4-6 breathing is to ensure that we're not having that rigid diaphragm. I looked for data on that, and so the rigid diaphragm happens in about 25% of the post-pelvic. It was post-pelvic, not pelvic specific to prostatectomy, but post-pelvic surgery. Kind of interesting.
Very interesting.
Yeah. So this 4-6 breathing. So I tell them at least 5 minutes a day preoperatively, more than that post-operatively. It's just a few breaths at a time, practicing. So it's the inhaling for 4 seconds through your nose, exhaling for 6 seconds through your nose. And with this, I typically will tell them if they're feeling a lot of gas pressure, then open their mouth as well so that they can expel some of that gas a little bit easier. So with that mouth control. This is just a typical thing I'll give them to practice at home. A lot of them have difficulty if they don't have any experience in yoga or in meditation or anything that's led them to breathing techniques. They have a lot of difficulty understanding the breathing. So I'll typically do something like this, and I'm not sure if this is going to work, but this is just a little thing I give them. Oh,
I think if you go in and enhance in your screen share, if you optimize for video.
Breathe in. 2.
can you see that?
Yeah, we can.
Oh, okay.
4.
Sorry, I'm going to let it go because I know I need to do something else, but in any case, this is through quietkit.com. So really simple. There's a lot of other ones out there. This is just one I think is not distracting, really easy, and the voiceover is very calming, right? I'm sure Susan has other resources too. So with everything I teach them about breathing, the most important thing, like I said, is no breath holding. If they're holding their breath while they're doing things, they're going to leak and they're going to have more sustained incontinence over time. So preoperative functional training with the monitoring of their breath holding and making sure that they learn how to do like a knack and exhale as they do a functional activity. So these are the things I try and work with them on. So we work on getting rid of gas, getting in and out of bed, in and out of their car. We actually go out to their cars and work on getting in and out of a car post-op. Sit to standing, lifting a gallon of milk or something equivalent, so less than 10 pounds, putting their socks and pants on, doorway stretch, so upper body, bowel movements. So we work on positioning and we work on breathing, going up and down stairs, opening a door, particularly a heavy door, coughing, sneezing, and bracing for general pressure, hernia prevention. So one of the things that people don't talk about going into this surgery is the opportunity that this surgery presents for hernias, right? So if you have increased pressure on a space that's weak at this point, you could end up easily with a hernia. And so I work a lot on just teaching them about hernia prevention. We have a pretty big substantiated hernia program, so it's easy for us to incorporate that into this. I teach them abdominal massage, again, to help move that gas and to calm any sense of pain they have, so they take as little pain med as possible. We work on scar mobility, so they have those 6 incisions. The belly button one is typically the largest one. That's where they pull the prostate gland through. I help them make a grocery list. So we're going to talk about food here in a minute, but we work on a grocery list with foods they like. I make them understand the value of protein in their diet, as well as some other things. Teach them how to monitor their fluids, signs of UTIs and infections. Very often in this process, you'll see if you're doing the pre and post prostatectomy programs, you're the first person they'll call or email. They can't get a hold of the surgeons. They can't get through the office. So very often they will reach out to us first, and we can help them identify what kind of care they need to seek at that point. I also talk to them and show them different pads and the types of absorbency so that they can get that preoperatively. And again, I work with them on pain management. So aerobic exercise in terms of preoperatively, it's good overall. We've shown in research the reduction in recurrence and mortality with some cancers. So it's important for them to have a long-term approach to aerobic exercise. I always start in that preoperative phase. The recommendation by the AUA, the American Urological Association, is 150 minutes of moderate intense aerobic exercise per week. I think every medical association has that recommendation, so it's not uncommon. And then just talk to them about how aerobic exercise can reduce their mortality overall, right? And then studies have shown these reductions in mortality associated with aerobic exercise. So nutrition and dietary recommendations. I started to feel more comfortable with this after I took a great course from Megan Pribble. And so getting involved with nutrition and dietary recommendations, particularly with these patients, has been very helpful to them and to me. I think some of the literature that's out there that's important, I've put here, but there's lots of other stuff too. There is a patient guide specifically for prostate cancer. Actually, there's several different ones, but they all speak to nutrition as well. So in terms of what I find for recommendation purposes, prior to surgery, I tell them, eat lots of protein, drink lots of water, have lots of fruits and vegetables, get yourself healthy, right? Start to focus on a healthy lifestyle, healthy diet. And if you're having a lot of caffeine or alcohol, try and eliminate that now or greatly reduce it so it's not so difficult post-operatively. So as with any surgery, it's important to eat those healthy foods to help the body heal. Getting the right nutrients enhances recovery, avoids complications. And so these are the recommendations I typically meet. And you'll see this in my sheet that I send home with them at the end here. So protein gives you the building blocks for repair of tissue. And it also helps with wound healing in general. I talk to them about good sources of protein being lean meats, poultry, fish, tofu, eggs, legumes, and nuts. I usually say a piece of fish or a piece of chicken about the size of your fist is about 24 grams of protein. And I want them post-operatively and even preoperatively to be around 60 grams of protein. So they can do that through their normal diet, and then they can enhance it with other protein sources. In terms of fiber, we know that that helps with digestion and with constipation. Again, trying to avoid constipation at all costs, which usually starts about the second week in post-operatively. So foods that are high in fruits, vegetables, whole grains, and again, legumes. Antioxidants to focus on cell repair and reducing inflammation. Remember, anytime you make incisions into the body, you're going to have some inflammation that results, as well as everything else that's going on. So reducing that inflammation is important. So focus on those foods that are antioxidant developing. And then vitamin C is another one in terms of wound healing and decreasing the risk of infection. And then iron for creating new blood cells and for also the wound healing process. More important than what I tell them to eat and drink and take care of is foods to avoid. So in terms of slowing down your recovery or increasing the risk of complications, and I've seen it over and over again, things that are make a poor outcome: alcohol, processed food, caffeine, and foods high in sugar. It doesn't sound unlike any other thing we hear from the medical community in terms of nutrition. And then in terms of basic exercises, so I'll give them something really basic like these 3 exercises to help with control, coordination, and strength. So these are just very simple. Very often I'll do these with biofeedback on so that they can actually see the pelvic floor or the pelvic muscles react as they're doing the exercises. And also just that visual cueing helps them to remember this when they are post-op. All right, so this is typically, I have this in like a little booklet and I had to actually cut it down into this little slide. So just to give you an idea of what I offer them preoperatively for the post-operative recovery. I tell them, to make sure that they have exercises, both breathing and physical exercises and walking that they should do, and I want them to do that. And then in terms of immediately post-operative, I'm not going to see them for about 10 days. I will see them after the catheter is removed, and I'll see them immediately after the catheter is removed. Tell them it's very important that there's no exercise during that time. I'll also send them a note, an email the day before surgery to remind them of that so that they don't get confused about that. I talk about when the catheter's in, they can do their breathing exercises, but that's it. They can walk, but that's it. During the first 10 days post-op, your primary concern is healing. So you're going to eat well, sleep well, drink plenty of water. Anything you can do to avoid caffeine and alcohol is important, and then limit those irritants in the bladder as much as possible. use fiber for good bowel movements, and fatigue's common. Take naps, give your body time to rest. I tell them to have a list of Netflix or other online movie subscription channels, like anything that they would watch, any books, magazine articles, podcasts. Get a list ahead of time. Do your grocery shopping list ahead of time. I work with them on that grocery shopping list, trying to help them develop good skills ahead of time. And then once that catheter is removed, they're going to return to pelvic floor therapy, and they're going to return to those exercises that we gave them at the pre-op visit. All right, post-prostatectomy. So 2 things the surgeons always talk about is nerve sparing. So this is just a good picture of where the nerves are around the prostate gland. And then they talk about vascular sparing. So I think this picture is just kind of interesting in terms of how much vascularization there is of the tissue and why erectile dysfunction happens, right? It happens because of, it could be vascular issues, it could be nerve issues, could be just general muscle weakness, right? And it could be a combination, which is what it typically is. So typically the surgeons will come out and say, I was able to spare everything in terms of nerves, because they're doing it with this robotic device. Vascularly, they're going to tell you, I was able to spare the major vessel, which is going to be that penile artery. And then they're also going to tell them about the catheter and how that was placed. And so there's 2 ways to do the catheter. The time of the surgery, the surgeons will typically do a suprapubic catheter and then a urethral catheter at the time of discharge from the hospital. So our patients go home with a urethral catheter for the 10 days. And the importance of that urethral catheter, let's just go back and emphasize this, is that that new sphincter, that external urethral sphincter, is forming from where they have attached that old internal urethral sphincter to the external urethral sphincter. And so having that catheter in allows that to heal, which makes it more patent. Okay, post-op, day before the catheter removal, 1 to 2 days in the hospital, pain meds and antibiotics, catheter for 7 to 10 days, breathing and meditation exercises, walk, no active exercise, no lifting, pushing, pulling, reaching, carrying. Definitely emphasize that. Anything that creates an internal pressure on that new sphincter is going to make it not as patent, and you're going to have more leakage. And I will say that is definitely a key to the success with the men that we have coming out now, post-operatively. Many of them are coming out without any leakage. It's amazing, honestly, compared to where we were 3 years ago, where they were coming in with multiple pads, measuring their pads, in terms of volume. So we've seen a huge shift, and I think a lot of the shift has to do with breathing. Kegels, limited caffeine, and no alcohol until you're continent. And in terms of post-op, after the catheter removal, just a summary to remind you, we give them pelvic floor exercises to do each day. We make that both fast twitch and slow twitch, and in different positions. Definitely standing is usually most difficult for them. Typically, the most difficult thing in terms of incontinence is that sit to stand, or getting in and out of bed, getting out of a car, carrying something. Those are typically the most difficult things. If they want to do a bladder diary, we encourage that, but they don't have to. It just helps them have more control, which is what this is all about. Behavioral changes to minimize incontinence. So if they can change the way they do certain things, like putting on their socks and putting on their pants, that definitely helps. And then again, reducing that intra-abdominal pressure all the time. Maintaining that urethral closure and standing. So we'll work on that in different positions. And in terms of walking, that start out at 4 to 5 minutes, then we increase for 30 minutes, 5 to 7 days per week. And we increase then the intensity with which they're doing that by measuring their heart rate. And then also trying to maximize the time between voids so that the bladder starts to get more weight to it, which tests that urethral sphincter. So initially, they'll probably go to the bathroom fairly frequently because the bladder will be small, because there's been a catheter in there and they haven't had to hold urine, right? So now we're teaching them to kind of get to 2 hours, let the bladder expand a little bit, let it give some weight onto that urethral sphincter. Again, that all helps with making sure that they're continent afterwards. And then we talked about no straddling, right? So avoiding bike riding, we avoid the golfing, weightlifting, and any high impact activities immediately post-op. These are some other considerations that definitely we explain to them and talk to them about, but it takes, I will tell you, a couple times before they really get everything here. So one of the things is the seminal vesicles and the surrounding lymph nodes can be resected depending on the extent of the growth of the neoplasm. And one of the things that I'm definitely focusing on for this year is the lymphatic component to this process. That's something that I don't have a good handle on yet, so I'm going to be working on that. But I do think that there's a place for lymphatic drainage and just lymph resection and what happens during this process. Something we definitely should be focusing on. The ejaculations will be dry, so they can expect that. The vas deferens is also dissected during the radical prostatectomy, so infertility occurs. And the other thing is that the shortening of the urethra is about 4 centimeters. We talked about that. So in a female, the urethra is about 4 centimeters, and the male 20 centimeters. So when they have that 4 centimeters taken out, they now have a 16 centimeter urethra. And then other possible side effects include the risk of erectile dysfunction. So we talk about that a little bit preoperatively and postoperatively, but don't focus on it because erectile dysfunction typically takes a much longer period of time. Many of these men are not experiencing any difficulty after 3 months, but if they are, that's definitely something that we start to work on. And there's lots of reasons why that occurs. So in terms of risk factors post-prostatectomy for incontinence specifically, it's more difficult to gain continence when you're older. So 75 years of age and older is a risk factor. If you have shorter pre-op and post-op urethral length, it's more difficult and can depend on the surgical technique and the volume of the excision, and then also the sparing of that neurovascular bundles. Obesity, conflicting evidence, and the previous prostate surgery. So, gives you a little bit of information here in terms of who's at a higher risk for more incontinence. One of the other things I like to point out to our patients is if they are diabetic, they may have a greater risk of long-term incontinence. And again, I've seen that play out a lot. And also erectile dysfunction. All right, so in terms of goals with these patients post-op, so in patients who have undergone radical prostatectomies, clinicians should deliver exercise training, and we saw that in the very first thing that the AUA recommended. So we have them do different types of exercises, and they're listed here. So it can be quick contractions, quick flicks, moderate intensity, practicing the neck with moderate coughs or sneeze or some kind of pressure, a sustained contraction for up to 60 seconds, some functional control, and then bladder training. So in terms of progression, these will give you some ideas. But in terms of goals overall, so one is to get the correct muscle contraction, and we're trying to optimize that striated urethral external sphincter. So cueing is super important. The cueing that works with females does not necessarily work with males in terms of training for incontinence. So with males, I typically use retract the penis, shorten the penis, pull the turtle's head into its shell. Imagine you're peeing up a wall. There's some of the typical ones. Trying to stop urine flow midstream is one way to test yourself, but that's not something we do all the time. So it would be a way to test yourself. I usually say test yourself weekly, see what your strength is like there. And then other ways to get the bulbar cavernosus and puborectalis strengthened for erectile dysfunction. So bulbar cues are more contract as if you're squeezing out the last drops, right? And puborectalis is more trying to stop the flow of urine or preventing the passage of gas. Continue with the breathing exercises and then discouraging bias to posterior contraction, abdominal activation, and breath holding. Those would be like substitutions to the actual thing that we're looking for. And then learning how to relax after a contraction is equally important. In terms of goal number 2, it would be for function. So you're trying to integrate those functional things and increase the duration and the intensity. And in terms of goal number 3, it would be for bladder training. Again, trying to hold that urine a little bit longer, aiming to get back to normal function with emptying 6 times a day, maybe 1 time per night. And then if you are having incontinence that's greater, then you're going to look at more of a clamp or urge suppression or things that you're eating or drinking that are causing that. Maintaining your hydration, continuing to work on that. And then in terms of goal number 4, so low intensity tonic contractions. So we had those in our program. And then goal number 5 is high intensity. So this would be also increasing the load as you do those. And then high performance training for those that want to get back to more complex tasks or whose work requires more physical effort. Post-void dribble happens, not necessarily, something that people want. So we work on milking and learning how to empty, work on relaxation and breathing, positioning, and then some other techniques like crede, stroking the inner thigh, rubbing the lower back. And then in terms of products, I just typically give them like a demonstration of the different products. I'll show them what I have available and then also show them pictures so that they can get those products preoperatively and hopefully don't need them postoperatively. I always say you can always donate them, but have them ahead of time. So these are just some of the things we work with. And then if physical therapy isn't working, so there's different options in terms of slings, artificial sphincters, and then I don't think we're going to have time for erectile dysfunction, but that was a basic overview of what we do in the pre and post-op for incontinence.
Yeah, we can always come back and do another one on erectile dysfunction. That would be fantastic. I know it's often questions that people have and how they handle that. So this is fantastic. If you don't mind, stop sharing. I have a couple of questions for you. And then anybody who's listening to the recording, if you're in the membership, you can go ahead and pop some questions into our Google chat and I'll share those with Colleen. And if you're listening from outside the membership, besides the fact that I want you to join the membership, you can email me some of the questions and I'll group them together so that they're similar. So she doesn't have to answer each specific question, but we'll group them into whatever it looks like that people are wondering about from the presentation. So the first question I have is in the hospital, I was kind of intrigued about the fact that they're actually staying for a couple of days. And they have the suprapubic tube, and they haven't switched over to an internal catheter yet. And there's all the restrictions. The one thing you want them to do is really do their breathing. How are they coping with getting in and out of bed? Is everybody on the team helping them learn log rolling techniques to get in and out of bed versus pulling up on a trapezius? A trapeze is going to, increase that load and intra-abdominal pressure. How is the team working with that?
So until we started getting involved, they were using that trapeze kind of stuff or allowing them to maneuver in bed without any training. So now they are learning the log rolling. They're learning that preoperatively. They're also having a visit with the therapists in the hospital. So they're not pelvic floor therapists, they're general therapists, but they work with them on bed mobility.
Absolutely. They can
Yeah.
do all of this. They can work with breathing, they can work with rolling.
Yeah. And the nice thing is we've been able to communicate with them, with those therapists about what our goal is with the patients,
Mhm.
right? And so they're reinforcing the same language that we're using.
Yeah, I think that's fantastic and something that we need to think about. I know that following some abdominal surgeries, they're actually even giving them a binder to help
Yes.
manage and hold. Are you all considering that? Are you worried that it'd be too tight and too much pressure? Or
So we have spoken about that with the surgeons, and they have 6 incisions there. And so they're worried about the incisions that are held together with the glue. So at this point, they're not doing a binder. I
okay,
think if they had somebody who had, a significant weakness ahead of time, that would be a good option, definitely.
yeah, I was just thinking about hernia prevention as well for some, not everybody, for some people who may
Yeah.
need that. Yeah, so that's great. And then when you moved ahead into your program, and I loved the fact that this program, although there's many things we can do with people, it's definitely a program that can meet people where they are. Some people
Yes.
are going to come along really fast. Some people are not going to come along as fast, and they're getting the education that they need to understand that, you know, that before I think they were just sending them home and not talking to them about drinking coffee and not talking to them about, fluids, and certainly not talking to them about preventing constipation.
Yeah.
And I think that may be one of the answers you'll have here in a minute for another question. But when you're talking about after the catheter's removed and now we're starting to bring in load, and they're definitely going to sneeze and cough and raise their voices and do things. Are you all working with them on, moving into a forward head position to cough and sneeze to avoid clamping down on the glottis and not being able to clear the airway effectively? Is that part of your training program as well?
So we do work with them on position, like posturing or
Yeah,
positioning.
perfect.
Yeah.
Hmm.
Yeah, we do. And I got that from oh gosh, I'm gonna forget her name, Lisa Radowski, right?
Hmm.
She was somebody who does a lot with the vocal cords and the pelvic floor. And so
Hmm.
we learned and listened to what she was doing. I was like, we should adapt that to what we're doing, right? And it made sense. So, like, a lot of the things we're doing with these patients are things that we've learned about from other areas of pelvic health and have seen how effective it is in what we're doing. So we've added it to what we're doing. That is one of those things, the posturing. Yes.
Yeah, so for those of you who are listening in the membership, the Glottis to the Pelvic Floor course is going to be up soon. And I spend a lot of time talking about that. I know Alyssa from Penn State, where she's doing some really cool research. I'm so excited that research is actually coming out on the things we've been doing since the 1980s and
Yeah.
before. I learned these techniques in the ICU in the AIDS wards. They all had tuberculosis, and I worked side by side with respiratory therapists and nurses because our job was to help them clear that airway. That was one of the things we did.
Oh,
And
perfect.
I really learned how to help them get up and I would even get behind them with their head and help them bring their head forward so that they could get in positions, we wanted to maximize the diaphragm, but we wanted them to be in a position to where whatever needed to come out could come out. And so this is fantastic. I love how you went and like, okay, what are they doing over here? And how can
Right.
we have this in? And what's going on over here? And not a regional, not a regional approach, but this is a full body approach, but it's also a full team support. Like the team, everybody on the team is saying the same thing.
Yeah.
So
I mean, we
there's
even
not,
have the
yeah,
surgeons saying what we're saying, right? Like
exactly. So
yeah.
they're hearing it multiple times from multiple people, and that just it reinforces, I think, the safety, like the client feeling safe because there's not a disharmonious conversation going on. One person saying this, the other person saying that, and the other person saying this. They're hearing it from all people, including maybe the surgeon that's on call that day when the other surgeon isn't on call. They're not hearing something different. And I think that for outcomes, to me, especially quality of life, getting people where they are feeling secure and safe, they're going to be more interested in doing the breathing exercises and
Right.
doing things and then the people who are not feeling safe.
Yeah,
They don't know what to
I
do, or somebody
totally,
said this and somebody said this, and so then they're kind of in, then they feel like nobody really knows.
yeah. I think the surgeons do a great job. Well, they've seen the outcomes, so they believe in us, right? And they believe in what we're doing. And so they say you have to go see this therapist, right? It's going to make a world of difference in your outcomes, which is really very supportive, and we're fortunate to have them. But the other thing is, like, they've really understood and bought into what we're teaching. So they're teaching it to other patients as well, not just these patients, right? Uh, it's all been a really positive experience.
Yeah, it's amazing. So just a couple of more questions just for you. Um, so regarding the post-op experience, is there anything that men who have minimal leakage do post-prostatectomy different from the ones who are experiencing more, aside from the risk factors that you went over? Like if they're, it's generally harder to recover continence if you're past 75, or things like that. Is it that they're just doing their program, or how are the guys that are really getting it? What are they doing anything differently than the ones that are like, oh, I'm still struggling with this?
So this is going to sound weird, but I think they believe, like they
That
kind of
doesn't.
believe
Mhm.
in the message. And so if we can get them to trust us and believe in what we're telling them, and they follow it, they come back and they're like, you were right. You were absolutely right. This is, and then the ones that are more difficult for us are the ones that either don't believe, or um, are so busy, like they just can't follow the instructions for whatever reason, right? And for a lot of them, they'll bring somebody. We always encourage, bring your wife, bring a partner, bring anybody you want, because if they hear the message, they're going to reinforce it too. And so at first I thought it was just the men being stubborn, right? Like not wanting to follow the instructions and not wanting to follow my instructions. But I think now more I realize they're just really scared.
Mhm.
And so that fear and anxiety that they have manifests in not following the instructions. So one of the greatest things I can do for those patients is just calm everything down, just make them understand what I'm talking to them about. But in order to do so, I have to have their attention, right? So I might spend time just saying, let's just, talk about what's your favorite thing to do, like make it not about the procedure, right? And then once I have them comfortable with me and we have some kind of relationship, then it's a lot easier to get them to trust me.
I think that's fantastic. I also love that one of the first things you do is teach the 4x6 breathing,
Yes.
and the in the heart rate variability world, that is a form of resonance breathing that is shown to increase heart rate variability if done over time. And for those listening, if you need to get people to calm down a little bit, you might even just start your first session with the breathing, the paced breathing, so they can just like settle in, and then you can ask the questions like, tell me who you are, tell me what you do, tell me what your passions are.
Yeah.
And
Yeah.
so,
That breathing is the most important thing.
yeah, it helps in so many ways. Like everything touches everything, and that really is one thing that will really change the nervous system, and perhaps they can hear a little bit better when we do that.
Yeah.
So finally, this is fantastic. Thank you for all the sharing, and
Oh,
everything.
thank
We'll
you.
definitely bring you back for the other part of the presentation that we didn't get to, which is the um, thing that probably
Erectile.
scares the men the most,
Yeah.
not
Yeah.
being able to have sex the way that they want to.
Yeah.
Uh, but one last question: what jazzes you about your group being mostly male that you see? What jazzes you about this population?
So I would have never thought that I would be working with mostly men on my caseload. So my caseload was about 75% male. And that was not something that I saw ahead of time coming. But the way that they are so grateful for what I do with them and the information that I provide to them. They're my best population. You know, they definitely make me feel the best about the work I do.
That's fantastic.
Yeah.
Thanks again, Colleen, for all
Thank
of your stuff.
you.
May we get a copy of your slides? If you
Yes.
mind sending us a PDF, I know people are going to be very interested in copying some of the research literature down and,
Yes.
and having that. And I would love to be able to share that. And for all of you who are listening, we will have I'll have this all together for you very soon. Thank you.
All right. Thank you, Susan.